Hey everyone, this week on Life in Motion, we are going back to school.
Going back to school in a doctor's office.
Yes.
Kind of.
Yeah, we are talking to a professional about all things women's health, from puberty all the way through menopause and post-menopause. So
this episode is very important, and it's for every generation. This is for daughters and wives and mothers and grandmothers and the men that love them. This is not just for women. This is for everyone. We believe that this is a topic that not enough people discuss, and we don't want you to miss out on this vital information because God designed you and cares about our bodies.
Yeah, this is an episode that you might want to take notes on. So get out your pens and pencils. And let's get started. Hey everyone, this is the podcast Life in Motion, and I'm Heather. This is Jamie, and we are in the middle of our summer of sex. And today we're going to be talking about menopause and women's sexual health in general. We have a special guest with us today, Dr. Kerri Anthony, and she is going to answer all of our questions regarding our anatomy, our whole physiology, and how our body works with sex and menopause.
A quick question, since we're sitting here together, do you want us to call you Dr. Kerri, Dr. Anthony, or just Kerri? Or your menopause MD?
Well, here you can call me Kerri.
Okay, great.
Yes,
okay,
but
good.
I am your menopause MD.
Okay, great.
So I am Dr. Kerri Anthony, board certified OBGYN, and I am also a certified menopause provider. And while I am a physician, I am not a physician to you as listeners. So there is a slight disclaimer that anything that we talk about here, I am not providing actual medical advice. This is education.
Kerri, could you briefly walk us through the different stages of a woman's life, like puberty, reproductive years, perimenopause? Just kind of explain the stages, because we are finding out that women don't know about their bodies.
That's true.
So
true.
Tell us all the things, briefly.
Yes.
Yeah.
So if we look at just the cycles of a woman's life, we kind of break that into reproductive cycles.
Okay.
So there's childhood,
Sure.
which of course is pre-puberty, and then there's adolescence, which includes puberty, but then brings us into the reproductive years. And so the reproductive years really start at puberty. So once we start ovulating, then of course we're able to reproduce. And that continues really through perimenopause.
Okay.
So if we look at the umbrella of the reproductive years, that includes puberty. It also includes perimenopause. And then once we hit menopause, we are out of the reproductive years. And so technically, menopause, it really is just one thing. You've gone 12 months without a period.
Okay.
And so really anything after that, you're technically postmenopausal, but a lot of people use the two words interchangeably. So once you hit menopause, you're menopausal, and then technically postmenopausal.
So I'm actually not saying this right, because I tell everybody I'm going through menopause, but I'm not actually skipping periods yet. I'm just getting hot flashes.
Well, so then that's perimenopause.
Okay.
But really it is the heralding into menopause. So exactly. So you can really use that language. Once we are going into menopause,
Yeah.
we still may have periods.
Okay.
We may not skip periods. And you could just wake up one day and it's been 12 months without a period and never have skipped. You could just go 12 months. So some women will start going from a 28 to 35 day cycle where they have a period every 28 to 35 days, or they may go 2 to 3 months and have periods 2 to 3 months for a year or two.
It's exhausting.
It is. Every woman is different. And so it's difficult to really understand. And not all doctors are trained in
That's
menopause.
what I want to know. Why do you care about this? Like, why did you decide to focus on this?
So as an OBGYN,
Yeah.
we should be the experts, right? Because we are gynecologists. We deal with the woman's reproductive body, right?
Sure.
And so we should be the experts. We should be the place that people come to. We should be the place that patients get all the information, and even other physicians may come to us for consults to help with taking care of patients. However, in training, which is many, many years.
Sure.
We don't really get a carved out menopause training. So for me, 20 plus years ago, when I was in training, we really just said, okay, if a patient has gone 12 months without a period, then they're in menopause. We didn't talk about perimenopause. We didn't talk about what happens. We knew how to work up skipped periods just to make sure you didn't have like an ovarian mass or some type of tumor, but not really treating a perimenopausal patient with hormones because we didn't start giving hormones until you've gone 12 months without a period. So there was no real training. There was no course. There was no curriculum. You just asked, when was your last period? If it was 12 months ago, then you could do hormone therapy or whatever therapy you wanted to treat menopause. And over the last several years, really kind of with the help of social media, we've been talking about it a little bit more. And so when I started my own journey into perimenopause, as an OBGYN who should have known that I was becoming perimenopausal with the symptoms that I had. I wasn't having really hot flashes, but mine was more emotional. And
sister.
Just rages, tearfulness.
Yeah.
And I'm not a person who likes to share tears in front of people. And that started happening. I was like, okay, something's wrong. I think I need to go and have some mental health therapy.
Right. How do you know if it's mental health or hormones?
It's hard.
Yeah.
It's hard. And if you don't have a physician who understands it and who can kind of walk you through it, then you may be in a cycle of just constantly treating with other medicines and never trying to balance hormones. And so my own journey really led me to luckily, I have a great gynecologist and went to see her without those complaints, but got emotional in the visit for no reason. And she said, it's time for you to start hormone therapy. I was like, no, I'm not having hot flashes. I'm good. I don't need hormones yet. I'm still pretty young.
Yeah.
She's like, nope, I think you need to start. And it was really starting that just opened the door to me saying, okay, if I didn't know it, and I mean, I think I know a lot, right? I mean, I've done all the trials. Like, this is me. I've done this for over 20 years.
Living. Yeah.
Then I decided to open my own practice and start taking care of patients who are perimenopausal and menopausal, and that's your Menopause MD.
Let's just talk about that emotional side and the mental side of it for a second.
Are we talking personal, or we're just curious as talking to Kerri?
All different, lots of things. Okay. So is there a way to know what's mental health or because before I started hormone therapy, I felt really down, dark. I even told my counselor, I was like, I don't really even trust my own thoughts. And they weren't like dangerous or anything, but I'm just like, this isn't me. This is not me. So what's happening? So my counselor wasn't like, we need to prescribe you, get you on some medications. But, it's like once I did start HRT, then all of a sudden my mood was like back to normal.
Yes. I'm just smiling because you sound very professional. Once I started HRT, sorry.
Yes, she's got the language down. She does. But it is difficult. And so the biggest thing is talking about symptoms. So if you start with a primary care, if you start with a gynecologist, just really being open and vulnerable at that visit to say, this is what I'm experiencing. Of course, we need to ask about cycles, right? Are you still having cycles? But again, you don't have to be skipping periods every other month for us to know that you're perimenopausal. Yeah. So for me, as a gynecologist, and it may be different with a psychologist or a psychiatrist, they may say this looks like maybe mood and maybe we should start an anti-anxiety, antidepressant. But for me, if we're in the age range, so really late 30s up to 50 is really when we start to see perimenopause happen. So if you meet that age criteria, so you're in the age. Now, if you're 21, 22, 23, it could be more related to cycle. So there's some things like premenstrual dysphoric disorder or PMS, and you might have really bad symptoms there. That's a little bit different. But if we're mid-30s and above and we're starting to experience that anxiety or rage or tearfulness or just being emotionally labile, and you may or may not have hot flashes. So we have to ask all the questions.
It seems like you also have to do some research and advocate for yourself. Because one thing I heard you say, Heather, that you're echoing is like, I had an annual checkup with my psychiatrist yesterday, and I'm so thankful that I worked so hard to find the perfect fit for me, because as I was talking to her, I told her how erratic my moods are, but how I'm tracking them to, like, every time Brian's just like, why are you so angry? like 3 days later, 4 days later, I start my period. So I go, I know it's connected to. And she's just like, I appreciate you doing that, because my first thought to you would have been, I want you to start tracking your cycle. Before we medicate an issue, I want you to track your cycle.
Correct.
And so now, like, she was in agreement with me. I'm in agreement with her, because I am on an anti-depression medication, that she's like, I want you to get your hormones checked. Like, this doesn't sound like anything to do with your mental health.
And let's just stop for a minute about hormone checking.
Yeah.
So I do want to.
Yes, good. Tell me.
But let me just take one step back.
Okay.
So for me, if I am seeing a patient and it sounds perimenopausal, then my go-to is we're going to talk about starting hormone therapy.
Okay.
And it usually takes about 2 to 3 months to really know how well that's working for you. But if I don't see clear signs of all of the criteria that we would make for depression or anxiety, so we kind of have to look at that, then we start hormone therapy, and then we follow up. And most of the time, I'll say probably 85 to 90% of the time, when I see patients back, there's a balance.
Yeah.
Now, may not be back to normal, so we still may have to make some adjustments.
Okay.
But if it sounds like perimenopause and we treat it like perimenopause, usually you're going to have a change in mood. You're going to feel like that just a little bit of anxiety has been suppressed. Now, in terms of hormones. So, if we're perimenopausal and we check your hormones, you have to be really careful, because in perimenopause, your hormones can be normal.
And they can change daily.
Yes, they can change every single day.
Okay.
So this is how we differentiate the two. The biggest thing, of course, is what we see physically.
Yeah.
Once you're menopausal, you are not having a period anymore. That means that your ovaries are no longer making estrogen and progesterone, the two main hormones that we make that really kind of control all of the things reproductive. Okay. So in menopause, done. Ovaries, the factory has been closed.
Yeah.
We're no longer making it. And so we give hormone replacement to replace what we're no longer making.
Okay.
In perimenopause, it's cyclic. So you may have, over the course of 3 days, a roller coaster ride from levels of estrogen that are almost non-detectable to higher than they've ever been in your life outside of pregnancy to then somewhere in the middle.
Yeah.
And so that's really where that emotional ability comes from, is because you're going from high. Estrogen makes you feel great. And so you've got that estrogen that's working, it's making you feel great. And then the next day, it's dropped to below the basement. And so now you're angry. Now, just one container that's empty in the refrigerator makes you scream, because who put the orange juice back in here and it's empty? Like, why didn't you throw this away?
Right.
And so that, if we check hormones in perimenopause, and I think that's where we see a difference between people who are menopause certified, physicians and nurse practitioners, to those who aren't. They will check your hormones. So imagine we check your hormones.
Yeah. Oh, you're normal.
And I call you and you're normal. And I say, hormones look great. Your estrogen, perfect. Progesterone looks great. And you just barely crawled out of bed that morning, and you are as hotter than you've ever been. You're crying, you're miserable, and you just want to crawl back in bed. And I call you and say, it's all normal.
You're fine.
You're great. And so that was me, 15 years ago, checking hormones for patients and calling them back and say, hey, hormones look great. Nothing for us to do. Imagine now, I know, because I've been on that side, if I had gotten a phone call and was told, there's nothing we need to do for you. You're great.
Throw the orange juice across the room.
And then that's when you say, well, then I must have a mental health disorder. I must have severe depression.
Yeah.
And so then you go down a different route. So now, we do check certain things. So when you come in, if you're complaining about hot flashes, night sweats, or irregular periods, we do want to make sure your thyroid is normal. And so that is technically a hormone as well. But we don't necessarily need to check estrogen and progesterone, because we know that it could be normal.
Yeah.
And if we want to check it every day for 30 days, okay, well, but nobody wants to do that.
Right.
Because if you're having those fluctuations, let's treat it.
Yeah.
Let's just treat it.
Yeah. Especially because I would imagine the way you're treating it, it's low risk, high reward.
Yes.
So it's not like we're doing something crazy.
Exactly.
Okay.
Exactly. And we adjust. So usually we start kind of at a lower or middle dose. And if we need to go up, we go up. If we need to go down, we go down.
Okay.
Yeah. And there are, non-hormonal options, but the gold standard for treating perimenopause and menopause really is hormone therapy.
Okay.
It is. So you can take supplements. They really are not going to stabilize your estrogen levels.
Fascinating.
And so, yes, they may help with energy or really energy. Not really more than that. And so we've got all these herbal remedies and vitamins that, are being sold online that say this is going to stabilize your hormones and this is menopause support. So support, yes, I can take multivitamins. I don't have to take the brand that's being sold on the internet for $199 for a subscription.
Sure.
If I want to take vitamin D and calcium, I can just get the generic from my local grocery store or pharmacy.
Okay. Yeah.
What about anybody that's breast cancer survivor, patient, any kind of hormone-related cancer? What would you say to them for?
So an absolute contraindication to hormone therapy is active or a history of breast cancer.
I don't know what you just said.
She said, if you have had breast cancer, don't do hormones.
Thank you. I was like, you just used a really big word that I didn't track with.
Contraindication.
Yeah, I was like, I don't know what's happening right now.
Yes.
Okay.
So, and I will tell you, that is, when I say that is systemic hormone therapy. So that is the hormone therapy that you take with a patch or an oral tablet that alleviates hot flashes and night sweats. That is different than vaginal estrogen. And so vaginal estrogen is the estrogen that we use vaginally. So if you have vaginal dryness or pain or frequent urinary tract infections, that actually has not been shown to increase your estrogen levels systemically at an amount that is significant enough to cause harm. And so that has been, over the last probably 10 years, something that OBs and endocrinologists have been fighting to kind of get the labeling. It has not been changed. But with oncologists on board, that is something we can give. So if you were diagnosed with breast cancer at 36 and you had chemotherapy and it put you into menopause, or you had to have your ovaries removed and it put you into immediate menopause, the vaginal tissue is getting thinner. It is tearing. It is really painful. It's difficult to have sex, and there is no natural moisture that's happening. We do give vaginal estrogen for that. And there are some very rare cases with an early diagnosis of breast cancer where the oncologist will support doing hormone therapy for those patients until the natural age of menopause. And so that would be if you had breast cancer diagnosed, went into a surgical menopause at 36 because we took ovaries out, or chemotherapy just took away the function of the ovaries.
You're starting to talk to me because you're like, let me put this in normal language. We took out the ovaries. Thank you.
So those patients may be put on systemic hormone therapy just from that 36, that year that they turned 36 when this happened until age 50. But that is that is a specific case, and it is in concert or conjunction with your oncologist.
So if your oncologist is like, no, you can't have HRT.
If a patient is seeing a menopause certified provider, we will all offer vaginal estrogen. There are just very rare circumstances where we have to actually say, okay, oncologist, this is what we want to do. Is this okay? And there's certain types of medicines that they might be on where we might not be able to. It's very, 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 very rare. But there are other medicines specifically for hot flashes and night sweats that are non-hormonal. And those are really good options. One is, it's just now been 2 years on the market. It is a fantastic option, but it really is only treating hot flashes and night sweats. So I want to carve a little caveat here. So estrogen, I told you, makes you happy. It just keeps us balanced. Hormone therapy is indicated for 3 things: hot flashes, night sweats, and to decrease our risk for developing osteoporosis. That is why it's FDA approved. However, women take estrogen and want to continue estrogen because of the beneficial side effects, meaning mood. So it helps to stabilize mood. It helps with joint pain. It helps with
that's what I need.
Sleep. For some, it may help with libido. For others, we may need to do additional therapy for libido.
Let's talk about that again in a minute. Keep going.
Absolutely. And so it really, it's all of the beneficial side effects that are the reason that we want to continue our estrogen. So if there's a big study back out in the early 2000s, and this is when everyone became afraid of taking hormone therapy. It's called the Women's Health Initiative. And I won't get into the details because that could go for several minutes, up to an hour. But overall, the black box warning got placed on hormone therapy after that study because women had strokes and heart attacks and blood clots in their legs and lungs when they were enrolled in that study. However, the age range of women was from 50 to 79. And so some women were 79 years old taking hormone therapy for the very first time in this study. Well, we know that our risk for stroke and heart attack increases as long as we are blessed to be on this earth. So the older we get, the higher that risk, no matter what we do. So if we're not taking any medicine, the older we just get more exposed to all the things, right?
Right.
So what we now have 30 years after that study is that, yes, there is an increased risk, but that happens when you are older. So if you start hormone therapy for the very first time after age 60, then yes, the risk will be higher. So we want to start hormone therapy within really the first couple of years of becoming menopausal, and at least in the first 10 years. And what we saw in the follow-up studies from the Women's Health Initiative is the group of women who were 50 to 60 who started hormone therapy. When we followed them for 20 years, the group of women who took hormone therapy actually had less strokes and heart attacks than the group of women who took nothing in that study. So it's actually, we also get a cardiovascular benefit if we start, a cardioprotective benefit if we start hormone therapy really soon into becoming menopausal. But the risk kind of goes up after 60.
This is also fascinating to me because I actually had a friend from the gym, because, you know, when you work out with the same people every day, I mean, we talk about this kind of stuff too.
Yes.
I just had a girlfriend send me a reel today from Good Morning America that's like, be careful because hormone replacement therapy could lead to breast cancer.
Yes.
So it's fascinating to hear you talk about these things. And this is yet another, like, you've got to do some research. You've got to talk to a professional that studies menopause. You've got to, you can't just trust just a reel that you see. You've got to really look into it.
Well, and that, I saw that yesterday too, because it came out yesterday. But again, there were women who were diagnosed with breast cancer in that study, but that was in every single group. So the placebo group, meaning the women who did not take hormone therapy, the group of women who took only estrogen, and the group of women who took estrogen and progesterone. But the interesting thing about that study is the lowest rate of breast cancer in all three of those groups in that study, the lowest risk, the lowest amount of women diagnosed were in the group of women who took estrogen only. So they had a hysterectomy, so they did not need to take progesterone. So they only took estrogen, but that group actually had lower numbers of women diagnosed with breast cancer.
Listen, I'll take some estrogen right now if you guys want me to.
Personally speaking, like,
how do we make that happen?
Mood is improved, joint pain improved,
I need some
sleep is improved.
I need all those
of it. That I would be. This is my own personal choice.
Well, you're not a doctor.
I would be willing to. I would be willing to do the HRT, knowing that there might be a slight risk, and continue.
Well, that's just like when you watch Eleanor laughs, like there's a commercial on, and at the end they talk really fast and they say, and you might die and you might do this. And she's like, good grief, people.
Yeah,
but
that's
like
everything.
Absolutely.
Everything.
Oh my gosh.
But that is, so it is a personal decision that you make, in conjunction with someone who has counseled you.
Sure.
And of course you can do your research. But yes, the risk is not zero, but tell me where the risk is not zero for any medicine that we take,
all.
And so for me and for most, it is, will my quality of life improve?
Yes.
Would I rather live my years feeling normal, feeling great, versus continuing to be miserable? And let's just recognize, we will never start making estrogen again. So if it happens that you're 50 when you go into menopause and you decide not to take hormone therapy, we know that your bones are going to get more brittle because that's what happens as we get older. We're not building that bone density. And if we know that we could have had a little bit of a cardiovascular protection, at least by starting hormone therapy, if we don't do any of that, then those risks are already going to be there.
Yeah.
Our risk for breast cancer is already 1 in 8 if we are women, right? So it's 1 in 8. So we already are walking around with the risk. That risk, we see that increase as we get older. So postmenopausally, we see more breast cancers. It's a slight increased risk. And so it really is weighing quality of life. I have had 70-year-old patients tell me, because again, 15 years ago, I was strictly into that study, and I said, "Oh, you're over 65. We've got to get you off of these hormones." And they said, "Oh my gosh, yes, sure, I'll stop taking hormones."
I'm listening to you.
Goodness.
Yes.
And then within 3 weeks to a month, there's a call saying, "Refill my prescription." now. I am miserable.
Okay.
I am miserable. Refill my prescription. And it took a while for me to I'm like, okay, well, we need to have another discussion because you need to say that you understand the risk for stroke and heart attack is now increasing.
Right.
And I had one sweet patient who just said, listen,
I'm
going to die anyway.
Yeah.
I'm going to die anyway.
Yeah.
We are all going to leave this earth. Do you want me to be miserable for the rest of my years, or can I just be happy? Can I feel normal? And I said, that's it. Yeah. Here's your prescription.
Yeah.
So, with anything we do have to weigh the risks and benefits.
Goodness.
Yeah.
You mentioned libido.
Yes.
Let's talk libido. And I think, we've talked before today, but I even think you said something the first time we met that I thought was fascinating. I don't know if it fits in here or not, but I can't even remember how we said it. Do you remember, Quinn? Like your earlier years when you're more prone to get pregnant or have a healthy pregnancy, and like the different the ways through life and libido and how that plays into it, and then help me as a 49-year-old woman.
Okay.
I mean, no pressure.
No pressure
Yeah.
at all. No pressure at all. The good news is I do this every day.
Okay.
We're good.
And we've already said you're not my doctor right
Correct.
now. You're just my friend.
Correct.
So just as a friend, let's talk about this.
We're just chatting.
Yeah.
We're just chatting.
Yeah.
It is interesting that we, as 40-plus-year-old women, expect to have the same sexual response, the same desire, the spontaneous desire that we had when we were in our maybe 20s or 30s.
Sure.
And I really like to just kind of draw a couple of illustrations, in our brain.
I like it.
So when we are peak fertile years, so the peak reproductive years, which are, late teens, early 20s, our bodies are designed to reproduce. So that's what we're supposed to do. We are here to reproduce. And so we have a cycle every single month that our hormones will increase. Mm-hmm. We will then ovulate an egg, and the goal is to get that egg fertilized by sexual intercourse.
Right.
And
the body's goal is this.
That is the body's goal. That's what we are. And every month, this is what's happening.
Okay.
And so then we respond to subtle cues.
Sure.
So if you walk into the room after your husband has just taken a shower and left the house, and you smell his scent, you're like, oh, wow, where'd he go? Like, come home.
Yeah.
You respond. Or just a little touch on the shoulder. And you're like, oh, hey. And you're excited. And you have spontaneous desire. Because right now you're ovulating and you've got about 72 hours to get this egg fertilized. And so all of the things are happening. You're having moisture. You are having that desire where you're like, I'm ready. Like, let's stop everything else that we're doing and take care of trying to get this egg fertilized, right?
Sure.
Well, once we go into perimenopause, we're not having those cycles as regularly. We may still have a few ovulatory cycles where we could get pregnant, which is very important. In perimenopause, even if you're skipping periods, you can still get pregnant.
Yeah,
okay?
Let's make sure everybody knows that.
So, yes, and hormone therapy does not prevent pregnancy. It is not contraceptive therapy. It is hormone therapy. So you can get pregnant. So let's just put that out there. But when we are not having regular cycles, we're not going to have those cues anymore. So we may have to work harder, and we may need to go from spontaneous desire to maybe a responsive desire or receptive desire where you have to work harder. So some of us have to get bifocals or readers when we get older.
Right.
Some of us need knee braces and elbow braces and wrist braces.
Right.
So we may need support for desire.
Okay.
For libido.
What do you mean by that?
So that's where we talk about
what kind of support?
Medication.
Oh, fascinating.
Hormone therapy, specific medicines for sexual desire, or we call it hypoactive sexual desire disorder.
Yeah.
But there are medications for that, but also having discussions.
Okay, yeah.
Talking about it.
Okay.
Talking about your needs, talking about how things are changing.
Yeah.
Talking about maybe pain with intercourse because we're no longer making the same lubrication that we used to, and the tissue there is thinner and it's more sensitive, and sometimes it tears. Yeah, so if every time you're having intercourse it's painful, now you've got a new fear.
Right.
And now when desire even wants to try to come up, you're like, I can't do that because now I have a response. I have more of a trauma response because it's going to be painful every time. But if your spouse doesn't know that, because you're not talking about it, Then they think she no longer desires me.
Oh, good grief. And
I'm
then
the
it's just a
problem.
big snowball.
And it becomes a snowball.
Yeah.
Exactly.
Yeah.
It becomes a snowball. And so the most important thing is to talk about it.
Okay.
And hey, this is what's happening. This is what's happening to me because I just want, how many husbands know about hormone therapy? How many husbands know about perimenopause and menopause? How many husbands even know that you make these hormones and that you don't make them anymore?
How many husbands even know how your anatomy works?
Correct.
Yeah.
Correct.
Yeah.
And
and females.
Yeah.
Like,
oh gosh, yeah. So there definitely women don't know what's going on down there.
yeah.
And so that's where you see someone that you can build a trusting relation, a physician that you can build a trusting relationship with, who can walk you through that anatomy and walk you through what's happening. But when maybe you've grown up and sexual anatomy and sex was a taboo subject that you never ever discussed, then why would you discuss it now?
Right.
So then you think,
I've been just fine this whole time. Mind your own business.
Yeah. And you think, I'm broken. And this is just how I'm going to be for the rest of my life. And now I'm miserable.
Okay, so a 25-year-old walks into your office, newly married, and she's like, I'm not enjoying.
Yeah, this isn't working out for me.
This isn't working out for me for whatever reason. What advice, where would you start with her?
So first we need to talk about anatomy. So that's when I was in private practice, which now I'm doing telehealth. So we cannot do this on telehealth. Yeah. We cannot pull out a mirror and get undressed from the waist down. Can't do that on telehealth.
Okay. But you could in private practice.
But in private practice, yeah. So the first thing we do is I would get a mirror if the patient was comfortable.
Oh,
and say,
she's not.
Let's say she is. And say,
I'm like,
this is going to be uncomfortable for you.
Okay.
However, in order to be comfortable with your body, we've got to kind of walk through it.
Yeah.
And so that's when I would let them hold a mirror and we kind of go over anatomy. Now, we'd have charts. So I can show you on the chart first, but it's better for you to look yourself.
Okay. Don't you think that the whole annual exam, pap smear, that the whole structure system of doing that, where you lay on the table and then they put a sheet blocking you from the lower half of your body, is kind of perpetuates that
I don't
ignorance?
love it. Don't love it at all. Don't love it. It's better for you to see. You know, for me to talk you through, this is what we're doing. And to do that, you're not covered from the bottom half. It's not, because again, taboo, it's almost making it taboo. We can't talk about it, can't look at it, can't do, So the biggest thing is first, and looking. So just knowing what's there and knowing what our bodies are built to do. If you've never talked about sex your whole life, you got married, it was taboo, then it's still going to be taboo.
Right.
And so how can you enjoy it if you've never been told that this is a beautiful gift that you have, that you both.
And these are the
enjoy.
operating instructions.
Yes.
Right.
Yes.
A young woman's in your office, she's having these issues and everything. Then what kind of resources do you point her to?
Yeah. There's one book that I really feel is helpful, really across all age ranges. And that one is You Are Not Broken by Kelli Caspersen. She's a urologist, but she is also, she sees menopausal patients and perimenopausal patients and kind of walks them through. Again, the group of physicians now that you see who are really supporting hormone therapy and trying to educate patients and just the general public are those of us who realize we didn't get the training, right? And so we went and got the additional training and we're like, how did this happen? How did I not know this? How could I be a gynecologist or a urologist and a female and not understand that this is what we're going to experience? And how many patients have I seen over the course of my career who I could have walked through this a little bit better, who I could have given a little bit more support for. And so I think that's a really good book to kind of walk you through. And it does talk about how for those of us who maybe had no exposure, no positive discussions about intimacy, then end up having issues once we are married and trying to have intercourse and having difficulty. And there's sometimes medicines that we have to do. There's other things that we might have to do if there's multiple diagnoses that we need to rule out when we're having difficulty there.
Okay.
And so there is a workup. But first we start with looking and talking through it. But then maybe a more detailed exam, sometimes an exam under anesthesia where you have to go to the operating room and you're asleep for us to make sure that there's not something structurally abnormal. But it starts with going in with the gynecologist.
Yeah.
With the gynecologist.
So you feel like if and we're talking about females right now, but if a female's having issues with sex, the first appointment would likely be a gynecologist. Is that what you are thinking?
As a gynecologist, that would be my recommendation.
Okay.
Because our toolbox is just going to have more diagnostic tools in it.
Okay.
And if you're seeing a family practice physician, that's great. And sometimes they will say, I think I need to refer you. So, if you're going in for a pap smear and you don't ever talk about anything else, then that's fine. But if it's specifically sexual and you aren't able to enjoy or even complete intercourse or even try to start, then I think you want to see a specialist, and that would be a gynecologist.
So gynecologist even before you would think sex therapy or pelvic floor therapy, or
especially if there's
gynecologist
training.
first.
Yes.
Okay.
Yes.
Okay.
Because most of the time we have the resources and we can send you to a pelvic floor therapist.
Okay.
Or we can send you to a sex therapist because we've done an initial exam. And we are also getting a history. So we have to talk about it. That's the thing, is that it's difficult. And some of us are a little bit more, I'm going to pull it out of you.
Sure.
If I notice,
Sure.
because some patients will come in and you just notice the tenseness, or there's just that intuition, and so that opens the door for the conversation.
Okay.
Versus sometimes you go in and you say nothing and you say, I'm here, I'm fine, everything's great, and then just let me have my pap smear and go home.
Yeah.
And then you miss it. And so and some of us actually ask the questions. And I think that's becoming more common as well.
Sure.
Just even on the intake form where we don't have to talk about it out loud, but there's questions. Are you having pain with intercourse?
Yeah.
Are you able to enjoy intercourse?
Yeah.
Those questions that then we can open the door to the conversation.
Yeah,
Oh, that's good.
I think that if there's anyone listening and they're like, I'm not enjoying this, or it is painful, to do your research at home and then go into the office with your questions.
Yeah, with your notebook, with your
This
things
is what
written down.
This is what I'm experiencing.
Yeah.
And this is what I want to know.
And maybe even practice it in your bathroom before you go to the doctor, just because it is
Practice
really
your questions?
Practice your
I was
questions
like,
because
what
it
are
is
we
really hard.
practicing?
It's
I'm
really
sorry.
hard to say.
Oh my gosh.
It is.
Yes,
And-
it is.
and
Yes, it is.
There's just, one other thing. If you are with a physician and you just still don't feel comfortable, it's okay to find another one.
Sure.
It's okay.
Yeah.
Not every physician is great for every patient, and that is okay.
Yeah.
So if you don't feel like you have that connection where you're comfortable, because the key when we're talking about difficulty with intercourse, or really any difficulty in our sexual function, you have to really be comfortable with.
Well, I think we do this in
person.
other areas of our life. You can do it with the doctor you choose. Do you remember when Cooper was getting his hair cut from Audrey, and he was at that later teen years, and every time he got his hair cut, he didn't like it. And she sat him down. She's like, listen, you're not going to be upset every time you come here. I might not be the one.
Wow.
And totally cool with me, but we're not going to do this. And then he realized he was overreacting. He's like, I don't want to leave you. And he still goes to her to this day. But I think that seems fine for a haircut. This is way more important than a haircut.
It is, but it's difficult because once you have possibly gotten undressed and had an exam, do you really want to have another one? Do you really want to go? And some offices, for that first visit, which is, the way I used to practice, you didn't get undressed before you met me. So I met you first. We had the conversation. We talked through what was going to happen once I left the room and came back and you got undressed. And so, that allows you to kind of get a little bit more comfortable and kind of get some of the nerves shaken off because we can talk through it. And then sometimes at that first visit, I say, well, today probably isn't the best day for us to do the exam. Let's just talk through it, and then let's come back another day.
Well, you sound like a real gem. It feels like with medical appointments these days, it's like I've got to get you in and out so quickly that it is. It's more difficult. I will say it's more difficult now to be able to do that, which is
why I'm doing telehealth.
Yeah,
because
yeah.
I get to spend an hour now with the patient. So we cover pretty much everything. And that hour still goes by pretty quickly.
I bet,
And But it allows you to be comfortable. And sometimes it takes about 5 or 10 minutes to get comfortable.
Sure.
Especially if you have seen other physicians and possibly you've been dismissed or you've been told there's nothing wrong or, everything is fine and you don't need any treatment. So sometimes it takes a little bit of time, but that's the benefit of telehealth, I think, is that we've got an hour to just really kind of unpack everything.
Sure.
What age should a female start seeing a gynecologist?
So the recommendation is at 21.
Okay.
Yeah. So if there are no concerns and we're not having any issues, and pediatricians can really help kind of regulate menstrual. So if, most of the time when girls start having menstrual cycles, they're pretty irregular initially, and pediatricians are great at managing that and kind of walking you through. But at age 21, that's really when we kind of make that transition over to seeing a gynecologist, unless we have other issues.
So your emotions, even postpartum, like you've had a baby,
Absolutely.
your emotions are kind of all over the place. And that's really important to pay attention to those emotions, postpartum depression
Absolutely.
and different things like that. But perimenopausal emotions, you're angry. You talked about rage.
Yes.
I don't know that I ever experienced rage, but I certainly have experienced high levels of irritation with small things, noises, lights,
Chewing.
sounds, chewing. I mean,
Don't get me
and
started.
it's like, I wish I wasn't annoyed by this. I can't help it. I try to breathe through it and whatever, but
Yes.
if I can hear you chewing across the room,
It's a problem.
it's a problem.
It really, same. It is my number one. My husband will,
Yeah.
yes.
It's a
I'm just
problem.
like, do you really have to chew
So are our emotions, our feelings, our responses valid? Or are they just like, it's just hormones, just ignore that?
Well, I don't know that I'd ever say ignore.
Yeah.
I think things are magnified because of really the magnification of hormone, the swing, so we're going from that high estrogen to that low estrogen. So it may be things that, you might have heard people chewing before. I've listened to people chew my whole life. Why is it now, even with my patch on?
Yeah.
So I'm wearing the patch.
Okay.
It still bothers me.
Sure.
It's still
Sure.
almost like nails on a chalkboard when I hear chewing.
Yeah.
And I never had an issue with that. So I don't know that we would dismiss the feelings.
Yeah.
But it's really learning how to work through
Yes, and
the
isn't this life?
That is,
Isn't this life in every area?
And having the conversation. So I will say, I think my husband, because I am a menopause provider, so he gets to experience firsthand what walking through perimenopause looks like, number one.
Right.
But then also, he is my video editor and all the things that we do. He's walking hand in hand.
For your social media.
For my social media. Yes.
We're talking about some very intimate things, so I just wanted to be
For
clear.
my Your Menopause MD social media and website. Correct.
Okay, just
only.
clear.
Yes.
Okay, just clarifying.
So he knows not to say, are you having a perimenopausal moment?
Oh my gosh.
Where maybe my 27-year-old will say, was that a perimenopausal moment?
Oh, that's funny.
And it's okay. I don't then rage on him because I'm like, no, you just, you don't understand.
Yeah.
But I think really walking through and supporting, it's almost like a PMS, right?
Yeah.
So the people around you, oh my gosh, are you about to start your period? You're being, is this PMS for you? Are you... I feel like those are not the words to really give us support, right?
And one thing you keep saying, Kerri, that I appreciate is communicate.
Absolutely.
Like, I don't think, oh my gosh, if Brian said to me, do you think you're about to start your period? Because I'd gotten mad about some chewing, then it's about to go off the charts, which, I mean, like, that's not even, but I do, we communicate a lot. And so I have noticed probably in the last year or so, he'll say like, do you realize you're unusually agitated? Is everything okay? Like, he's like, do you feel it? Because I don't always feel it. And so like, we've gotten to a point where he can ask me in such a way where I'm like, I'm still mad, but I start paying attention. And then I go, I'm about to start my period. Like, he and I have ebbed and flowed through life together where he's like, do you realize you're very short with all of us? And I usually don't realize it. Now, that might not be the approach. You were like, oh, that might not be the approach for
I'm putting
Kerri.
myself in that situation because I'm trying to imagine if Eric said that to me, how would I respond?
But
I think I would probably be more agitated.
Right, but it's like the open communication of like where, if he were to say to you, are you having a perimenopausal moment? And you're like, oh, I can't go for that.
Yes.
But the ebbs and flows of relationship, of deciding when and how do we talk about things and before they happen. Like, how do you want me to respond when you are off the charts angry and I go, this is abnormal. So Brian doesn't say you're being abnormal, but he does say,
he'll say you're a little bit more agitated.
Why are you so angry today? How can I help or whatever? Because sometimes it's just like, I need you to mow the lawn. And then sometimes it's just like, oh, I didn't know I was angry. And I had no idea.
I do like that. I do like that because it is opening the conversation, and we each may receive
it's
differently.
Personal.
And
it's
so
personal.
I think for me, what I want is usually for him to say, "What do you need?"
Yeah.
Without saying you're definitely a little bit more agitated today, but just, hey, do you need something? Like,
and
what
that
do you need?
seems true to personalities. Like what I don't want is anyone to hug me or touch me. Like when I'm like, if somebody's just like, are you okay? Like when I'm feeling those feelings, I'm just
I
like,
don't want to be touched. I'm with you.
Everybody better not.
I think that might be more common that we don't want.
Okay, that's faster. I'm just like, oh my gosh.
No.
And I don't want anybody tiptoeing around me like, oh, mom's feeling it today. Let's stay out of her way.
Right. And you know how I am. I'm super direct. So it would stand to reason that Brian being gently direct is going to be.
It works.
It's how it works in my house.
Yeah. And I think we figure that out, right? We figure out what works in our house. But the key at the base of this is communication.
Okay.
And so, talking maybe before we even get to that point. So in the doctor's office, as we hit our 30s, is the conversation happening of, hey, what should I be looking for over these next few years? Should I be looking out for perimenopausal symptoms? And then actually having the conversation at home, I am going through a transition period shortly. Like it's coming, it's around the corner. And this is what we could expect. So that's where reading, getting your resources. I mentioned You Are Not Broken. There's another book, The Menopause Manifesto by Gunter. She's an OBGYN, where you have there are guidebooks out there where maybe we need to pick them up before we start having symptoms. And also then have the conversation with our spouses and be open about it in front of the kids as well.
Yes. We hear this a lot from listeners of like, when do you start talking to your kids about sex even, which is the other side of our conversation. But as a gynecologist, do you have an opinion on that?
I do.
Okay,
I do.
Good.
Good. I have opinions on everything.
I love opinions.
So really when we think about so let's look at childhood, adolescence, puberty. So for girls, and that's my specialty, the average age to start puberty is anywhere from 8 to 12.
Sure.
Sometimes in African-American girls, it might be a little bit earlier. And we've kind of changed that over the years.
That? Don't know.
Don't have that. Don't know. But I think when I first started medical school, I think we said the average age was maybe starting at 11, and then we've kind of gradually decreased that. There are many different thoughts about, hormones in our food and, we being exposed to estrogen, obesity, of course, the more abdominal fat we have, we may be producing more estrogen at an earlier age. So there's some reasons. But so if we look at that and we say, okay, the average age, for puberty, well, the earliest onset could be as early as 8. If it's earlier than that, then we call that abnormal, and that needs another workup. Okay. So we really want to talk about it before we get to that youngest age of 8. So I usually recommend, and even in my own home, so as a gynecologist, as a Christian woman, as a mother, my goal was we're going to start the conversations probably about age 7. Okay. We always use, the real name for body parts. And so we want to take the taboo away. So even as we're potty training, we are using the real words for body parts.
I didn't do that, but that's okay.
And that's okay.
Yeah.
That's okay. You do what works for you.
Well, and didn't even know at the time. Yeah.
Yeah. And I think with social media and, people
we know so much
you've got so much more. There's so many things that I might have done differently.
Oh, sure.
Now that, but I think just having, and it doesn't have to be all the details at 7.
Right, right.
But we just open the door where it's not taboo.
Yeah.
Yeah.
And then we continue to build on that. There's definitely, now I can't remember the books because mine are 27 and 23.
We have books we love that we'll drop in show notes again.
Definitely, you know, we went through all of the books.
Yeah.
And then for girls, we did the American Girl,
The care and keeping.
the care and keeping of you. You know, those are great for you to just kind of sit down and say, this is what's going to happen. I think if we start talking about it at that early age, one of the biggest things is that the children, your kids, are getting that information from you.
Right.
And not from their peers.
Right.
Yeah. And
And
social
whatever,
media.
and social media,
Yeah.
and whatever wrong, right things that the peers are,
Right.
you know, whatever that interpretation is, then you want your children to look at you as the authority.
Absolutely.
And even though as they go through their teen years, no matter what we say, they feel like we just don't know anything.
Right.
But if you just lay that foundation, then eventually, maybe not in the teen years, but eventually they may come back and say, you know,
Yeah.
you did lay that foundation. Like you
Yeah.
were the authority. Like you did, you know, I really understood it. But take the taboo away from it. I just, you know, I remember being I was in puberty, but I don't think I had hit my teen years. And I remember being at the dinner table and my mom saying to my dad, you need to tell her what these boys are thinking. Like the things that they're going to say. And like, you need to go through that. And he's like, I'm not discussing any of that. And so then I'm like, well, wait a minute.
Yeah,
What is it that
I need to know what I need to know what's happening.
What
Yeah.
is it? What am I missing that he's so adamant that I shouldn't hear? So of course, then that opens up the door for all these things.
Yeah.
No, have the conversation.
Yeah.
Open the door.
Oh, yeah.
Talk about what's normal.
Right.
Talk about use the real terms, but take the taboo away from it.
With Eleanor, because she's 11, and we're close in a different way because same gender, but also I'm an older parent than I was with my boys, and just really hoping she doesn't have to walk through certain things that I did, that it's very normalized, these conversations. Where we talk about things like this, it feels like all the time because our body's changing.
Exactly.
And they are uncomfortable at first
They are.
until you just keep doing it.
Yeah.
Like you just get back on the bike and pedal again. And you just
Yeah.
try it again and talk about it a little bit more. And so like she goes to camp next week and like, what if I start my period while I'm at camp? I'm just like, well, we're going to be fully prepared. And you go right to the nurse's office and have them call me.
Yeah.
And, you know, they can help you, but I can help you over the phone, but we'll talk about it on the front end. And the likelihood is like slim. But it could.
It could.
Oh my gosh, it could.
It totally could. And she's just like, I
Absolutely.
just want to,
Yeah.
she's actually kind of excited about it. So she's like, I just want to make sure I have everything in the bag. I'm like, okay, we will. We'll have it all packed.
But I think, you know, having the conversation and making periods normal as well.
Yeah.
So I think even just myself, who, you know, I've started earlier than my peers. And so it was a secret, you know,
Right.
nobody needed to know that, you know, and so I'm trying to, we couldn't carry purses at school. And so you're trying to figure out how to get to the bathroom.
Oh, my
And,
goodness.
like, no, like we're all going to have one. Like we do not, this is not, a period is not taboo. This is normal. This is our normal body. This is what's supposed to happen. Make it normal. Talk about it.
Even talking about the boys.
Yes.
The boys know this is normal.
Correct. For both genders. Again,
Right.
exactly. So,
Right.
you know, my son is my oldest. And so we talked about it openly so that he knew this is he's got classmates, right? Like, let's be support. Let's know what's going on. And also the other thing when we talk about, you know, how early and making sure that we are educating our children, but just also talking to them about the hormonal cycle. So just like in perimenopause, we're on a roller coaster. When both girls and boys start puberty, there is a hormonal roller coaster.
Even with
there's,
boys.
There's emotions.
Okay.
There's sometimes anger.
Oh.
There's tearfulness. They are, because when you first start, it's just haywire until you start having regular cycles. Now, I'm not saying boys go through a cycle like that. I'm just saying with the hormones kind of
just changes
changing, there is this emotional, and they don't understand it. And so they think something's wrong with them.
Oh,
They go
goodness.
to the room, they close the door, they don't want to come out, they stay in all day. Talk about it so they know this is normal.
Yeah.
And it's for just a period of time. It's not forever.
Yeah.
You know?
And didn't we all experience, especially in high school, boys making an insult out of if you were at all irritable, she must be PMSing.
Yeah.
That's the answer to if a girl is not happy.
Yes.
Right. And that's not just the answer. But then on the flip side, if you turn that negative conversation into a positive one, it could be. And so, you don't completely dismiss it. I had one of my boys one time ask me if I think they'd heard that type of comment at school. Like, do you feel like you're angry right before you, wonder, is this real?
Just trying to figure out.
Yeah,
is
what they're saying, is this real? And I was just unfortunately, I do. Yeah. And I think a lot of people do. I mean, that's not always why I'm angry. Sometimes I'm just angry to be angry.
And if you go back to the cycle. So what's happening is, that the estrogen level is rising so that the lining of the uterus can really thicken to support that fertilized egg.
Yeah.
So that egg is hanging out, waiting to get fertilized. Yeah. It doesn't. So then the hormone levels fall.
Right.
And as that estrogen level falls, then the uterine lining sheds. So you had your happy high estrogen levels.
Yeah.
And we didn't get a fertilized egg to implant. And so now we're shedding. So imagine, just like postpartum, you had that estrogen that was just keeping you great,
so
and now
great.
it's dropping.
Now you just,
so that's kind of how we imagine the hormones. So we're reacting to that fall in the estrogen levels. And so then we're, for some of us, it's, really severe. So for some of us, it's, milder symptoms.
Sure. Yeah. I don't know if this is the place to talk about this, Heather, but I was just thinking this is such a different conversation than we typically happen on the podcast. So why do we care about these things as Christians? I think every woman should know this, but oh my gosh, I looked fine.
You did look fine.
Thank you. But why do we care about this as believers?
Dr. Kerri, do you see a different attitude in your visits between, if I mean, that's not necessarily disclosed, but between religious women and non-religious women or Christian women? Do you see a difference in attitudes?
That's difficult.
Yeah.
In telehealth, I don't maybe know as much as I did in private practice. I think it really kind of depends on what age they're coming in and what the issue is.
Yeah.
So I think, talking about sexual function and libido issues, that is a sensitive topic for anyone.
Okay.
I don't know if maybe some of the patients who came from a Christian background were more hesitant or not. I don't know that I see a difference, but I think, when we talk about this normal cycle and the way that our bodies are designed to function, we should not be ashamed of it. And I think because just the word sex, for many, if you are a Christian, you shouldn't be talking about sex.
Right.
And so we don't talk about sex in the church in that manner unless we're really kind of talk about it. We're designed to reproduce and be fruitful and multiply like that. But we don't talk about issues with sex or what if we aren't connected. What if we...
And I think that's why, Heather, I can't speak for you, but that's why I feel passionate about this because I feel like there's so many young adults currently in our church that will ask me questions about this topic. And they didn't talk about it in premarital. They didn't talk about it with their gynecologist. They didn't, they went in blind because they had only heard at the church, no sex before marriage, you get married and it's good, which we've said this a million times, and then it wasn't.
And I will say that. So from that point of view, so seeing a patient premaritally as a gynecologist who had not had intercourse and who says, okay, what's going to happen on my wedding night? Mom didn't talk to her about it. They definitely didn't talk about it in their counseling, the premarital counseling. So they would come to me and say, so what's going to happen?
Right. Yeah.
What am I going to feel? Is it going to be painful? Will it hurt? What should I do?
Yeah.
And so,
that's a pretty brave young woman.
Yeah. But I had several of those women
I'm so
who
glad.
would ask. And so then we're trying to walk through what to expect and then possibly following up afterward with the issues of, oh my gosh, I've waited my whole life for this and I hated it.
Yeah.
What do you mean it's supposed to, was it supposed to be magic where there was supposed to be fireworks? Well, we might have to work hard to get those fireworks. And we both he might not have any idea of how to
Right.
help
Yeah.
you create fireworks,
Right.
and you may
Yeah.
not have any idea on how to help him create fireworks.
Right.
And then if we're afraid to talk about it, then you think sex is terrible.
Yeah,
And so
yeah.
we will only have sex to reproduce and get pregnant and have a baby, and then it's just
making
gonna
it
always be-
even
yeah.
harder for this next generation than it was for our generation is the fact that they're seeing this play
unrealistic.
out in porn and
Yeah.
things like that, where like we talked about this last month when we recorded, but like you have this picture that you're always ready. It's very easy. It's very passionate. It always feels good. And everybody's on the same page.
Yeah.
Without talking about
You know,
it.
Nobody talks about anything.
No.
It just
just happens.
And
Yeah.
that's so unrealistic.
Right.
And so I think this is the place to have the conversation, to not look at, that unrealistic view.
Yeah.
It's fake. You
Yeah,
know, that
yeah.
is not what's going to happen in your bedroom. And I think where else can that conversation happen if it can't happen here? you
Right,
know?
right.
So I think it's important to have the conversation, to take the taboo away from it, so that it's not the very first time you're ever talking about it is after you've gotten married and you've never even looked at your own anatomy. It's okay
Yeah,
to
yeah.
know what's down there
Yeah.
and know really where pleasure happens for most women.
Sure.
Which for most is not because a penis has gone into the vagina.
Yeah.
That is not going to magically feel great.
Yeah.
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 Well, and I even think like what's fascinating is even in a household like mine where I feel like we're really, really open. I told my sons, I have young adult sons, 20 and 18, that I hope they listen to the summer podcast. And they're like, not a chance, because we're talking about sex. And I'm like, we're not talking about like me and your dad. like we're, I know. Like but just the thoughts
Yes,
that
they
people think
can't-
like,
yeah.
oh no. And I'm like, I really think some of these things would be helpful for you. But it's fascinating because like even the taboo, like, oh my gosh, Heather and Jamie are talking about sex. I'm like, what are people thinking we're going to say?
Yeah.
Like, everybody
Because
take
that's the thing. They think
everybody
it's-
take a deep
if
breath.
you talk about sex, it's going to be this graphic.
Yes.
Just no. Let's just talk
Let's
about
have
like
some
the-
healthy
Yes.
conversations to set everybody up for
Yes.
success, to point you to resources, to
Yes.
get you, like everybody take a deep breath.
Yeah.
It's
Yes,
okay.
it is okay.
So-
Yeah, it is okay, and it is okay to have a healthy sex life.
Yes,
It is-
it's God's ideal
Yes.
through changing
Yes.
seasons. I even wonder. This is just a spiritual wondering. I even wonder if the changing of our bodies and our hormones and all of that, if God doesn't think like we have to continually woo one another the whole way through. You can't ever go on autopilot. It's the same with the Lord. The moment you go on autopilot, your relationship
yes.
dries up.
It
Yeah.
does.
Like the Lord is constantly calling you back for different and more. It's why the word is living and active. And you
Yeah.
can read a scripture one day and then the next day read it a totally
it's
different
totally
way.
different way.
And I
Yes.
think our marriage is that
That's
way.
perfect.
It's one way in the beginning and then it completely changes.
Yes.
And you have to pursue one another like you have to pursue the Lord.
Yes.
And like, I mean,
yeah.
I sometimes sit here and think like, well, we got the raw end of this. Our hormones keep changing, but what if that's all part of it?
Yeah.
It-
No, I
It's
love
all,
that.
It's all the wonder and the awe and the renewal of coming together and finding a way to make
Yeah.
it work yet again.
Yes.
Yet again. I don't think this is, I used to think this is such a raw deal. What if it's not?
Yeah.
Yeah. That's
It's-
it. Yeah. I love that. I love that.
I've read some different social media posts about how menopause is an evolution for women.
Yes.
That can we talk about that for a minute of
I
how
say that,
you go
yeah.
from you're in these different stages. You're in childhood and teenage years, and then traditionally, this isn't
Some,
for
yes.
everybody, but you enter a stage of motherhood, which is a lot of sacrificial living with your body, your time, your emotions. There's a lot of sacrifice in that, and then you hit menopause, and I feel like you're kind of like done with other people's problems, and
Yes.
Okay, I like that.
and you I think you can evolve into something new,
Something beautiful.
something beautiful.
Absolutely. So I 100% agree.
Okay.
It is an evolution. So I think prior to social media And again, this group of physicians and, you know, those of us who are in that 40 to 50 range who now are really open and talking about it, when we were in training, it was the end. Like the doors are closed, factory shut down, you know, like just
it's time for you to move into the shadows.
Yeah. Just go sit
Pasture
somewhere.
the cattle.
Sit somewhere in a corner.
Oh my word.
Exactly.
Okay.
Yeah.
But, you know, in my opinion, it really should be the most beautiful time of life, right? Because you are not driving kids from this place to that place.
Yeah.
You are not, if you do not want any more children, you are not at risk of pregnancy once you have hit menopause. Now, remember, in perimenopause, you can still get pregnant.
We're not getting pregnant. We're not getting pregnant, but thank you.
But, you know, now, so you're not worried about if you are active, you don't really need any type of protection.
Sure.
You don't need any of that. And it's a time to reconnect. And so, you know, when you're empty nesters, I think for us, you know, we were nervous. Like, what's going to happen when we become empty nesters? Are we going to realize that the only thing that was keeping us together were the kids, you know, raising the kids?
Right.
And it's a time to reconnect. And I when you said that, Jamie, like it was, yes, we evolve. Like Heather, you said evolve, but you said, you know, a time to kind of reconnect and
pursue each other in a new way.
Pursue in a new way. I love that. So it may be different, right? And we may have to work a little bit harder. We may have to talk about it. We may have to touch in a different way. We may need the dishwasher emptied in order to have our brain relax.
Yeah.
Like, so we might need different things, but I feel like the connection can be deeper in this stage of life. And, you know, I don't know if you guys are seeing social media, but it's like the We Do Not Care Club. She's so great. Oh my gosh, I love all of her posts. But it is, at this point, we've raised the kids, you know, we just don't care about all the things.
Right.
And so we can really focus on the things that matter most now.
Yeah.
And if this is the partner that I'm spending the rest of my life with, we really need to open up a new door and have adventure now that can be even better than when we first got married. But you have to work.
Yes.
So just like to work on your this is what you were saying, Jamie, is your relationship with Christ. You have to continue. You have to continue to read. You have to continue to pray. You have to daily work on it. Well, why shouldn't we work on our marriage daily as well?
You've basically said this, but just so I can hear these words come out of your mouth, because we do have listeners that ask all kinds of questions. Just, would you tell me, can a post-menopausal woman enjoy sex?
Absolutely.
Okay. I know you've said it and you've danced around it, but I just wanted to hear you say that because I think people wonder.
You can enjoy sex, and you might enjoy it even a little bit more. Because
tell us
because you're gonna we do have to work a little bit harder, but I think if you start opening, let's just go back.
Okay.
When you first got married, did you talk about what you needed? Did you talk about what felt great? Did you say, oh, I like this, I don't like that? That conversation, we didn't have those conversations. Now, maybe now, and I would encourage the 20-year-olds getting married now to have the conversation. And you might not know it until you try a few different, like you're not going to know until you try. But we didn't have those conversations. Well, now, because again, the We Don't Care Club, I don't care about the other things, but I do care about this. And so I'm going to be direct and I'm going to tell you, I don't like that, but I do like this. And you can also tell me, you don't like that, you do like this. And what may have worked before, because men, you know, they are more.
I'm like, what are you thinking?
So
tell me, please.
So for men, you know, they really are more visual. You know, that is really kind of where that desire comes. Where for us, for most women, and when I say this, I mean most. I don't mean everyone.
Sure.
But for us, it's more mental. So we need to mentally prepare. So we may have to think all day about what will I do tonight? I'm going to initiate sex tonight, or I'm going to initiate some type of intimacy. And men may say, oh my gosh, she just got out of the shower and I happened to walk in at the right time and I'm watching her walk naked to the towel and I'm ready.
Yeah.
And he's just looking at you and he's ready and you get in the bed and you're like, no, the bed is for me to sleep. I want to grab that pillow and I want to go to sleep. And they're like, no, you came out naked and so, so you're ready. So you're ready. And I'm like, no, I'm not ready. And so you're talking about it now. And you are saying, okay, for me to mentally decompress and to be in the moment, the kitchen needs to be clean.
Yeah.
You know, I've asked multiple days in a row for you to take out the trash or to do this, do that.
You sat there watching football all day. And then, and I
need that. Or I need a word of encouragement or a word of affirmation during the day.
Yeah.
So that is building up my tank for tonight. Or it may be oversharing. Maybe for you, going to bed at night, you really want to sleep. You are exhausted at the end of the day. And maybe for you, it would be better if we approach this first thing in the morning or in the middle of the afternoon.
Candle in.
Yes.
Calendar in some afternoon delight.
And that's okay. You can write it in a calendar. When you are menopausal, you can write it in a calendar. Say every Tuesday, Thursday, that's what we're doing. And for you, if it's better at night, then we're going to do Tuesdays at night and Thursdays in the afternoon. So I think at this point, you know, we're not worried about what everyone thinks and we're not worried about having to get here in this time crunch. And so we can open the door to conversation. And even if that means, there's one book called Better Sex Through Mindfulness. And it really walks you through some exercises where you are focusing on what you feel. How many of us have focused on what we felt in early days of marriage? We just really haven't. And so one of the exercises is that you are sitting naked on the bed together.
I mean, I'm just like, oh my
naked.
goodness.
You're sitting, not laying.
Seriously.
So all of this is out, okay? You're sitting.
Kerri.
Okay? And it's in a
so I can't be in a...
No. You are, like, it's out. Like, everything.
Oh, Kerri, I don't...
Whatever.
Everything's drooping and rolling.
Exactly.
Okay.
But it is a non-intimate set. Like, you are just... Maybe, what does it feel like when you touch my leg? It is non-sexual. The whole session is non-sexual, but it is focusing on what you see and what you feel in non-intimate touch. Just, how does it feel when he touches my thigh? How does it feel when he touches my arm?
Different when I'm sitting naked than it does when I'm sitting with clothes on.
I guess you could just lay on your side and put your head. But I think just being comfortable in your nakedness. Together,
which to me feels it feels so much harder to do at this stage. Not that I was ever just sitting around naked in my 20s.
But you're right. But
but it's different.
But we felt a little bit different about our bodies then too. You know,
like I just like that. This whole menopausal belly thing, I think, is real.
Oh, it is real.
And I'm just like, are you kidding me?
It is real. It is real.
Like,
The other day, my oldest daughter, she's 21, had gotten a new dress, and it's a form-fitting dress. And she was like, Mom, I tried it on, it was so cute. And she's like, you would like it too. And I'm like, I don't think my lumpy body could get into that dress.
No, my body wouldn't like that. Anyway.
So yes, a postmenopausal woman could have the best sex of her life.
Okay.
At this stage.
We've got a specific question here. Would you read that?
I will. I've been married for this is not me. I'm reading
this one.
This one. I'm 65. I've had a hysterectomy. Sex is no longer enjoyable, and my body doesn't tolerate estrogen well. Maybe you need vaginal estrogen. Anyway.
Oh, look at you, Jamie.
I've been listening.
Yes.
Okay, anyway, my body doesn't tolerate estrogen well. My husband, who has a history of emotional abuse and unresolved trauma, now struggles with erectile dysfunction, but still expects sex. I feel emotionally and physically disconnected, yet he constantly asks for it. Do my feelings and needs matter too?
They do.
They do matter.
So your feelings and needs matter.
Yeah.
So my first question is, have you guys had a conversation? Have you talked about your feelings and his?
Right, both.
So there's a lot to unpack there, but I think starting with being comfortable having the conversation and what is it that he feels he needs, right? And why? You know, is it just because you grew up and you were told that your wife should always be ready at the drop of a hat when you are ready? right? Because that's unrealistic. So
But
we need to talk through that.
But he has ED, so
I know.
he's not ready.
So, well, but if he's expecting it, the question is he on medication? And so is he taking the medication every day?
and then he's
saying,
expecting it because it is
I'm taking the
time.
medication, you know?
Yeah.
And so then
We both go, yeah.
So then we have to be realistic there to say, maybe we don't want to take the medication every day, and maybe we need to put it in the calendar. But first, let's go back to why it's uncomfortable for her. So if she doesn't tolerate estrogen well, what types of estrogen has she tried?
Yeah.
There's multiple types. There's oral, there's a patch, there's a gel, there's a spray. You know, and when you say you don't tolerate it, is it because you're having systemic symptoms? So are you getting a rash because you used a gel or a patch? So should you take an oral tablet?
Oh, okay.
Is it causing your blood pressure to be too high? Like what? Yeah. So we have to look at that. There are multiple options there.
Sure.
But vaginal estrogen is great. Really, I just haven't found anyone who does not tolerate vaginal estrogen because there's so many types. Okay. The cream is messy, but it's usually what we try first.
So how much do you want this to work?
Yeah. So what do we want to do? And what have we tried?
Yeah.
And have you talked about it with your physician? Have you said, when we say, sex is it painful? And so have we given vaginal estrogen at least 3 months?
Okay.
Or did we just take it for a couple of weeks and say, oh, it didn't help and I'm still having pain?
Yeah.
Because we really need to try it for at least 3 months for it to absorb and actually thicken. It can thicken the tissue down there.
Wow.
Yeah.
It can help with lubrication. It can help keep the pH balanced. And so have we done those things? But first, it's conversation.
Yeah.
You have to talk to your spouse.
Well, she says, I'm feeling emotionally and physically disconnected. So
we've got to
Potentially
connect.
they aren't. Yeah.
So we've got to
There's
connect.
a whole lot of issues
And
there.
where's my key? It's worth it. It's
Absolutely.
worth it. Like we don't quit pursuing the Lord. I don't think we quit pursuing the husband that God gave us. I think we just, well,
I think
it's just hard sometimes. But it's okay.
When we say, have the conversations and be open, again, men and women think differently. And so without your spouse knowing that maybe it's painful for you,
right,
or that the libido's not there, it's not happening, you're trying to work through that. At the same time, they're thinking she doesn't desire me.
Right.
And so I can't even tell you how many in my career I've seen in this age range get divorced. Like it's over. Like because maybe she doesn't desire me, and so there's no connection, and we're not talking about why, and then it must be because she doesn't love me anymore. Or she thinks I'm not attracted to him because I should naturally respond.
Yeah.
I should naturally have desire. And so maybe because I'm not, maybe it's because I don't love him anymore, or maybe because we should be.
This is why the church has to talk about stuff like this, because like some of these thoughts, these recorders that go on in your mind are like, we would only do this with conversations that we're keeping taboo. Like, let's be real.
Yeah.
I don't always feel like going to the gym, but I understand that the benefits outweigh my not want to. And so I have to push through. And like some of these, you've got to have a conversation that's radically uncomfortable because it's worth it in the end.
I think normalizing the conversation about menopause, just figure out how we can get that in some days where we are actually talking about it and making that normal.
Yeah.
And then it allows you to open the door to all the other conversations for men and women. So it's not just that we women are talking about menopause.
Right.
Everyone needs to hear it.
I feel horrible for the average man that doesn't even know all the hormonal things that a woman is going through. No wonder they're beating their heads against the wall. No wonder they're like, she must not desire me. She must not. Zero education.
Correct.
And that's a tough place to be.
Yeah.
It is.
Well, I think
else?
the narrative with menopause is that if you are using the word menopause, then you must be old. And, we're far from old.
Yes.
Far
Well, and
from
certainly not
out
in
to
2025
pasture.
where we live for so much longer.
Yeah,
I mean,
but there's a cycle happening here. Feeling emotionally and physically disconnected. I think that when you're at this age, it's like you're not going to just be putting up with what you put up with before.
Correct.
Like it's a new it's a new
your tolerance is lower. Like you just
that's a good way to say that.
both of your needs are not being met. And
Right.
Yeah.
Right.
this has been a lot of information just hitting on everything from our emotions to our bodies, everything. So I hope that you were taking notes. If not, you should go back and watch it again and take some notes, write down some questions that you might have for your doctor, or write down some things that you might want to talk to your spouse about.
Sure.
Open the door of conversation with your doctor or your spouse.
God created sex. It doesn't have to be taboo, but it's up to us to start a conversation with the appropriate person.
Yeah.
So that's kind of our charge to you. We're willing to surface the things that are a little bit uncomfortable, but then you have a part to play as well.
Yeah.
So we hope that you will take this information and use it so that you can have an enjoyable sex life with your spouse. And Dr. Kerri, thank you for joining us. Anything you want to say before we wrap?
Well, first of all, thank you for having me.
We love you.
It was great being here.
Yeah.
I loved it. And you can follow me on social media at Your Menopause MD on Instagram, Facebook, and TikTok. But I just have to echo, have the conversation. I think having the conversation with your physician, having the conversation with your spouse, and actually doing a deep dive with yourself. Mm-hmm. Having that conversation with yourself. What is it that you're needing? What is it that you're experiencing? Write it down and have that conversation. You can have the best sex life in menopause. It can happen.
Thank you so much for tuning in. We love you guys. We will see you next month on Life in Motion.